As I was saying, I want to thank Holly and Christine from the ATTC network for allowing me to do this presentation. We did do Referral to Treatment Part 1 last Wednesday, and we're going to finish up today. I'd like to thank those, welcome those back from last week, and welcome any new participants as we move forward. During this presentation, let me see here. Okay, give me 1 second. I'm having some technical difficulties here. There we go. Last week we covered just some of the expert interventions. We looked at some of the barriers of why people have a challenge with receiving treatment. We'll talk about some of those today. And then last week I kind of shared my experience on how I identify patients as it pertains to needing referral for treatment. A little bit about me is I currently work on a trauma center. I've been there the past 5 years, so I work with a lot of inpatient patients, and upon doing screenings, anyone that is in need of treatment, I usually will refer them to additional treatment services. I'll talk about some of the challenges that I typically experience being part of a hospital system as far as discharging, waiting list, and some of those. However, today we're going to talk a little bit about some of the collaborative efforts that are important in order to provide screening and brief intervention for linkage to services. Some of the efforts that I have made and what seems to work with myself and one of my coworkers. I am going to kind of go into detail about the Acm Levels of Care, which is the American Society of Addiction Medicine. What are some of those levels of care and dimensions? I'll talk a little bit about that. And then I'll look at some of the specific patient populations. For those of you who do not know, a lot of the information I'm going to present today, I don't believe in reinventing a wheel. A lot of resources are out there. So what I'm going to do is present a lot of information that is out there so that you can actually access it. So we will be looking at resources from SAMHSA, NIDA, ASAM, and some others. When we look at referral, just recently SAMHSA came out with a nice manual called, it's a TAP 33, and for those of you who are not familiar with SAMHSA, you actually can go into their publications section and really explore well over 50, they're either TIP or TAP manuals regarding substance use, abuse, and special populations. And this one came out pertaining to expert, and there are also some other, I think it's TIP 24, don't quote me on that, but it talks about how to address substance use in primary care settings. And so when we look at establishing the referral process, there are some key things that SAMHSA has identified, and some of this is by way of some of the grantees that they have sponsored over the years, who've kind of come back to say, hey, these are things that are essential. One of them, obviously, is to identify patients that meet substance abuse and dependence criteria. And really, it depends on the screening tool that you're using that kind of determines, you know, how that's going to look. But always remembering that screening is a way to identify, but it does not allow you to assess and actually make a diagnosis. A referral process is the ability to identify appropriate treatment programs. And again, you know, what is in your area and what is in your surrounding area. We have a very transient patient population that comes to our hospital setting, and so although we're here in the Columbus, Ohio area, I'm real familiar with the county that I reside in is Franklin County, but you know, we receive a lot of people throughout the state and even outside of the state. And so it's important that if people need treatment that I kind of know how to access those programs. Facilitating engaging patients into treatment programs, that's another reason why for the referral process, to develop strong linkage. Opportunity to engage patients in appropriate level of care, and one of the things that I like about this particular training, and you know, as you educate yourself further, is that when you present recommendation for further referral, a lot of times patients are like, well, what do you mean? What does that mean? You know, does that mean inpatient? And so understanding levels of care kind of also and also allows you the opportunity to educate patients, so it kind of reduces some of their anxiety. If you don't have a referral process, it does kind of impede the whole process of expert, because you are going to run across a percentage of patients who are going to need referral treatment. When we look at the statistics of expert, you know what, let me just say from what I see every month at my facility is that there's usually at least 20% of the patients that I usually see about 100 to 115 that actually need referral to treatment. Some of those are interested in treatment and some patients are not. And then lack of proper referral will and can prevent access to treatment and opportunity for patients to address other psychosocial medical issues. The reason I stress that, and depending on how long have you been in the field, but there's always a saying that addressing the alcohol and drug use is about anywhere from 10 to 20% of the problem. It's the other things that come about. So it's important that when we refer people to treatment, it's not about just total abstinence from the substance itself, but what are some of the challenges and consequences that have been a result of one's use. I showed this slide last week, but I thought it was important to kind of put it in this as well, so we kind of get an idea of the numbers that we're talking about. This is the National Survey of Drug Use Health that's done every year. It usually comes out 2 years later. But if you look at 2011, when we look at substance abuse and dependence, we're looking at about 20.6 people in the United States that needs actual treatment services. Now, what's alarming about that I also shared last week is that 95% do not receive the treatment that they need. And so the whole issue is where are all these people? If they're not in treatment, where are they? And of course, we all know they're in our mental health centers, they're in jail, they're in our hospitals, our emergency rooms, our physicians' offices. But this number was the one that really just kind of sold expert to me, because having been in the addiction field for 15, 16 years, I was always on the extreme end of it, understanding that people were abusing substances well before they got to the point of abuse and dependence, and that it's time that we begin to try and capture people at an earlier phase of their substance use, whether it's binge drinking, harmless drinking, or illicit drug use or misuse of medications. And then when we start looking at treatment, I think it's important we understand, when who's entering treatment, and still, across the country, it's primarily alcohol. You have the marijuana, the painkillers is a huge concern, and some of the other substances. But I think it's important that sometimes, particularly working in the medical field, a lot of medical professionals want to kind of get stuck on the illegal substances, and I always kind of continue to bring to the forefront that alcohol and painkillers, which are legal substances and legal prescriptions, are causing a huge epidemic in our country. And then this is just an indication of how treatment admissions over the years have kind of continued to increase and will continue to increase unless we address this. It's unfortunate I was unable to show a series of slides that we have here in Ohio from 2002, and it kind of gives us for a 5-year period, how the admission system kind of has been inundated with prescription pain medications or admissions for prescription pain medications and or heroin addiction. So when we look at substance abuse and dependence, of course, these are the two, when we look at disorders or diagnoses, whether it's the DSM-IV or the ICD-9, there are criteria, and like I said, depending on your screening tool, some of the tools get at some of these criteria. What I didn't put in this slide is that for your substance abuse, we're looking at a 12-year period, and we're looking at someone meeting one or more of these criteria over a 12-month period and what you keep seeing is recurrent, and continued. Those are real important, that when you're screening patients and you're asking those extra questions so if I have a patient who comes in and they're hospitalized for a motor vehicle crash due to alcohol use, I explore their alcohol use in direct relation to the crash, but now I'm asking this patient, is this common? Is this a normal thing that you're doing? Because that helps me get at the, is this substance abuse, I'm sorry. And then here you have substance dependence. Again, we're looking at a 12-month period, and we're looking at 3 criteria out of these 7 to kind of determine that. Again, some of that's within your screening tools. Not the exact same questions, but it kind of points to the criteria. This is a slide that I showed last week, but I really wanted to kind of make a point now that we're going into referral to treatment. And last week what I said was, from this point here, this is where our effort lies. The screening and the brief intervention, I'm sorry. Now what happens is when we get someone who starts meeting those criteria, or for example, if you use the audit, which is what I do, it kind of tells you based on the patient's score when they should be referred out for further treatment. And so when we go, this is what we're looking at. We're sending a patient to another facility to get this comprehensive assessment, the interventions, and as well as the outcomes. And we're going to talk a little bit about this when we look under the treatment. Barriers to change is huge. When we're sitting talking to patients about needing further treatment, very rarely do I get patients who are just outright, I don't want treatment, no thank you, get out of my office kind of thing, get out of my room kind of thing. I usually get about 2 denials or 2 refusals per month when I'm wanting to address someone's substance use. But what's common though is the shame and the guilt. Feeling as though they're a bad person, because of their substance use, feeling guilty because of the things that they've done, because of their drug use. Some patients just have this, it won't work out, this is just too much, too overwhelming. It's, to go into treatment and deal with everything else in my life. The lack of support. You have a lot of people whose family is in active addiction and their whole peer support is in active addiction. And so, they lack the support. Some have a lot of fear. And then some have the success and the failure. And some people allow the failure to pretty much dominate not going to get further treatment. And so part of our interventions, when I have a patient say, well, I don't think so, or, maybe not right now kind of thing, I kind of explore, in more detail, what's going on with that patient. Because it can be some of these barriers and others. Motivational interviewing is definitely one of the approaches that I use in working with patients, and definitely exploring the ambivalence, and that can be some of the barriers to change. Looking at some of the individual feedback from patients, and for those who say, I don't want treatment, but I do want to stop using, and I do want to stop drinking and all this, and being able to explore what that really means. And sometimes patients don't really know what that means. They just know they don't want to go to another facility. And so kind of exploring those things to kind of encourage patients based on their scoring that, a treatment program can really help them out. This is a slide from a study that was done on motivational interviewing. And, I don't know about many of you, but when I went to the addiction field in the 1990s, early 1990s, confrontation was huge. Motivational interviewing really wasn't on the scene, at least not, in my area. And so when we began to look at change talk, what clearly shows is that confrontation really doesn't produce a lot of that. Confrontation at times can be very demeaning, and a lot of patients just are really challenged by it. And what I find is interesting when I go in and meet with patients at bedside, even when I mention alcohol and or drug use or alcohol and drug use labs, you can kind of look at the nonverbals of it's kind of like this, oh, she's getting ready to get me. And that's really not the case, but that's the history, that most patients are so used to being attacked, that when you bring motivational interviewing into the into the fold, it really shocks a lot of patients. Another thing when we look at barriers to change or barriers to treatment, or do they go to treatment, or are they interested in treatment, is really explaining what are some of the pros and the cons of treatment. I use this technique when I talk about recommendations, and I want the patient, to kind of share with me their pros and cons, and then I can share mine. I also look at the pros and cons of their use, and I always ask them that, what is the benefit of the smoking of the marijuana or the drinking of the alcohol? What does it do for them? So I can get a better understanding of what are some of those other psychosocial issues that are going on. This is a time when you kind of see that slide, that little animation. This is a time where I kind of open up and allow for a couple questions, and in this case, because there are a lot of mental health professionals and social workers and treatment professionals, feel free to comment on some of the information that I presented. So at this time, I'll kind of open it up.
I don't see any questions yet. Since you did ask them for that, why don't you check back in about 10 minutes and we'll see who types anything in.
Okay.
Thanks.
So let's dive into collaboration. For me, I believe, and again, this could be agency specific. For me, it was important that I did a lot of collaborative work internally at the hospital, because I work with a lot of multidisciplinary staff, from trauma surgeons to pain management, behavioral med, orthopedic, plastics, I kind of physical therapies, occupational therapy. And so I really had to communicate internally, because even if I have a patient who does want treatment and would love to go directly from the hospital to treatment, some of my challenges is because of trauma injuries and the need for legitimate pain medications at discharge. Some patients, although they're interested in treatment, really may not be appropriate for the treatment setting because of further surgeries. And then there are those cases where I have patients who really want to go to treatment, and then I have to work with the medical team to, if they're on pain medications, to bring them off of those pain medications, before we start, to any direct transfers. I don't get many direct transfers from a trauma unit due to the mere fact of the nature of injuries. However, that may not apply across the board to other settings. And then, of course, the external collaboration. Now, this is some key elements that's from the National Center of Substance Abuse and Child Welfare. If any of you have an opportunity to actually go onto that website, it has tutorials that really, and it's free, and you actually can get credit for each tutorial, that it gives you more in-depth understanding that within the child welfare system, how not only the treatment centers, child welfare system, and the legal department really had to come together collaboratively in order to ensure that mothers or fathers who were in the child welfare system were getting the treatment that they needed, but everybody had to stop and evaluate the challenges that each discipline faced based on timing and recommendations. And so these elements, if you go onto the website, you will see how what they did to kind of create this collaborative arrangement where they even have a website. What I think now is missing is the medical field that I think would be pretty dynamic. I'm not going to go into great detail of each of these, but one of the things that's important is the underlying values and principles. They vary from a medical setting to a treatment facility in some cases. For example, if I have a patient who needs legitimate pain medications, the treatment centers in the area in which I reside, most patients are not going to be able to take those pain medications while in the treatment setting because it's abstinent-based. So sometimes I have to be realistic and not put a patient in a jam or a bind because I know these two systems and how they operate, and I have to explain that to the patient. The daily practice and the daily service to patients is pretty much what I kind of added to this, is that, my job is obviously to do screening and brief intervention and make the referral. Training and staff development is huge on both sides. One of the things that I've done in this area is I've done a lot of screening and brief intervention trainings at area colleges and community trainings to invite substance abuse counselors into the fold, because a lot of them are not aware that screening and brief intervention is being recommended and a huge initiative within the medical setting. And I think it's important that they understand that, because now that is a different referral set that they're used to. They're used to primarily the courts, employers, or child welfare workers, and so some of them aren't even aware of screening and brief intervention within the medical setting. Budgeting and sustainability is always huge as it pertains to who's going to do going to do what. I know sometimes, if I have a patient who has a waiting, who's looking at treatment, but there's a waiting list. There's a waiting list for an assessment. The hospital, based on discharge demands, is not going to keep that patient in the hospital for a week for them to get an assessment. They want that direct linkage, and that's where that whole communication comes in. So what happened was I had contact some of the area agencies and speak with some of the mission supervisors and managers to kind of say, hey, this is what we're doing, this is what I'm seeing over at Grant, this is what patients look like, this is what our process looks like, how can we work together? And so what I've been able to do is develop professional relationships, so that when I make a referral to a particular agency, I'm going to speak to one person and one person only, so that we can create that smooth transition. And even for patients who aren't able to have a direct link or transfer from the hospital bed to a treatment center, at least that patient has signed a release of information. I've contacted the other agency. I've spoken to the main contact person. Now the patient is leaving the hospital, and once medically able, they know who to contact at that facility. And so, it's not like, this patient is foreign to the facility. Now, obviously, one of my greatest concerns and one of the challenges that I have is I don't have that staffing to do the follow-up. And so the thing is, it's very high risk or challenging, because patients who are ready for treatment now, and then now having to wait a week, 2 weeks, 3 weeks, 4 weeks out, that gap is huge. Some have followed through, but that's a huge challenge when you're making referrals from a hospital setting and there's waiting lists. Some things to consider when making referral. Again, this is with I think collaboration also internally works with the patient. Hey, I'm not contacting any agency unless the patient is saying and giving me permission to do that. So we're definitely looking at patient stage of change, and this is pretty much your folks that are in that preparation action phase. Patients plan on, how to address the issue. So if I have patients who are interested or patients who are not interested, I usually take time to say, okay, tell me the things that you plan on doing to further address this issue, or to engage in treatment services, or what do you plan on doing in the in-between time in order to abstain from substances, before you actually can engage in services. Insurance providers and self-pay. I can't stress this enough. I think with the new health care, I'm not quite sure how this is going to look. I would like to believe that it's going to provide people with the services that they need as it pertains to alcohol and drug use. But patients who do not have insurance, our indigent population, our self-pay, they're relegated to one treatment center here in Franklin County. And that's just the reality. We have 3 of them. So obviously there's a waiting list versus someone who has insurance actually has access to 3 treatment facilities. And it's just a matter of, who's available. A lot of times with insurance providers, as you all know, based on whoever the carrier is, a lot of times they have their own process that the patient has to call the 1-800 number and talk to someone, do something over the phone, and they tell them where to go. And see, these things are important because these are the things you have to communicate to patients. Some patients that I've ran into says, hey, I have insurance, I can go in for, inpatient treatment for as long as I want. That's not true, because you and some of you know, insurance companies are going to dictate those days. Your policy may say 28 days, but the insurance company may give you 3, 5, review, give you additional days, or want you to step down to outpatient. So patients kind of need to know that. Knowledge of treatment levels of care, we'll talk about that. Release of information is huge. One of the things with screening and brief intervention, particularly in the healthcare settings, they're used to HIPAA, and they believe that HIPAA pretty much will manage it all. But once you put substance abuse interventions in some of these settings, you're now putting the federal law of treatment in there. So you're looking at, I believe it's the CFR 42. And so I had to work real hard with our attorneys at the trauma center to help them see that it was beyond HIPAA, and that worked out. Obviously, the case management tasks as far as making the phone calls, making the contact to the treatment provider. Some of you may go as far as having written agreements. I don't have those. Mine's primarily verbal, and it's been working for the 5 years I've been there. Then, of course, for those patients who cannot go directly into a treatment program, exploring the option of 12-step support meetings. And of course, Celebrate Recovery is more of a biblically based support system. And, I never forget the families. Some of the families are pretty worn out, particularly from a trauma center standpoint, because the very thing that most family members feared has happened. And so their loved one is now in the intensive care unit or critical care units, and not sure if they're going to make it, or if they do, families are sad one moment, furious the next. And so I have no problem sitting down meeting with families to begin to explore their support, not only dealing with the history of addiction, substance use, but this current tragedy. Confidentiality, I kind of talked a little bit about that. That's where the release of information. And mine goes a little bit more in the hospital setting. Particularly at this point in time, it's very busy. So we usually have 2 patients in a room. And when you're dealing with drugs and alcohol, you pretty much want a private room to have these conversations. And so it's tough, to have a curtain between one patient and the next to have these conversations. So I kind of approach a patient and we kind of discuss how we're going to talk about it without all their information being disclosed. The other thing that I do with confidentiality is we do report into the electronic medical record, and I have worked with legal in our billing as well as our coding and medical records, so that when I do, myself and my coworker, when we do screenings and we do our documentation, it goes under substance abuse consult. And what happens is that there are certain ways that we redocument so that this information is not sent out with the medical record. That's important. Referral challenges, I've kind of talked about some of those. Obviously, patients who clearly are scoring very high on the screening tool, but they're at that contemplation stage. Obviously, as a therapist, my job is to try to move them to that next level. Sometimes it works, sometimes it doesn't. The waiting list is always an issue within our treatment centers. That is just a common theme in our area. Treatment providers' reluctance to take referrals. Sometimes you will have, and I've pretty much have been able to, do the release of information and speak with folks, but they still ultimately want to speak with the patient, and so I usually have to, make that phone call happen, within the patient's room. Patients are just overwhelmed by the voicemail system maze. And, just kind of like, I'm just tired. The insurance lifetime cost, indigent status, medically unstable, not only just pain medications, but there are some patients, I think I shared last week, based on their injury, broken back, broken femur, broken neck, they really can't get up and move about in a residential treatment program. They, in some cases would probably have to do outpatient, but those are some of the challenges that's a reality. Your inpatient settings are like, no, we can't take them because, they're not going to be able to participate in treatment services, and then patients are just overwhelmed by the injury itself, let alone having to, be transported around and sit in a group process. I talked about the hospital, discharge demands, medications, and then mine is the lack of resources for follow-up. The thing that I think is important historically with hospital systems particularly is they were taught, whether in school or just the system alone, that if you see a problem, if you have that incidental finding, or if you see that there's alcohol and drug use, give the patient some information and send them on their way. Give them a packet. Well, just recently I had a nurse come to me who was in the OBS unit, and that was their model. When these folks come in, we've identified it, give them a packet. And she said to me, she says, I just don't think that's working. Just giving someone some copy documents. And that's the other thing that I like about screening and brief intervention, the whole expert process, is that it goes beyond those packets that in some cases can be very outdated. So even now, when you're developing these systems or developing the screening and brief intervention, referral treatment in your system, you really look at your referral packet. Is it up to date, updated? Make it look nice. Is it copies faded? Make it presentable for patients. And then the other thing is being able to just kind of know what are all the reasons why people don't receive treatment. We saw earlier in the one slide it was like 95%, but why? And the survey clearly indicates it. For some, it's the insurance, and you'd be amazed. Some people have insurance and don't even realize they have the resource. And for those who don't have insurance, they don't know that money comes from the federal government to the state level, to the county level, to certain agencies within the community, and in order to access care. So they think, I don't have a medical card, I'm not paying for insurance, no one's going to help me. And that's when we can kind of say, hey, I know you don't have insurance, but there are some agencies. Although limited access, there are still agencies. Not ready to stop using. I don't know about you, but I've had patients who said, lady, I've been drinking this long, I'm going to keep on drinking. And you have to respect people for where they are. Obviously explore, in more detail, but some people are very clear about it. Some people are confident they can do it on their own, because they've done it before. So it's not uncommon for a patient to say to me, ma'am, I stayed off this stuff for 6 months, 8 months, a year, 2 years before. I think I can do it, on my own again, because they have that confidence. And if they're pretty much stuck there, I then explore, and if for some reason you're not able to pull together the amount of time that you did in the past, what would it need to look like in order for you to seek further treatment? So having the patient say, hey, I'm not saying it's not going to work, I'm just saying if by chance it doesn't, now what? What does that have to look like? So patients kind of know and can verbalize it. Transportation to whose issue. What isn't on here is child care. It's not uncommon for women that I work with that say, hey, I don't have anybody who's going to watch my children, and that's where I begin to say, hey, maybe it's not residential treatment. Won't we start with something? Won't we start with some kind of outpatient? Treatment centers do have outpatient services, and so these are just some of the things to keep in mind. I think sometimes in the medical field, my experience has been there's just this blanket, they don't want to get help, and that's not necessarily true. Screening and brief intervention allows the conversation to be had so we can kind of find out what are people's reasons for seeking, some of the challenges for seeking treatment. The other thing that's important, and I'm saying this because in where I reside there are a lot of treatment centers. There are a lot of mental health centers, adolescent programs, adult programs, and so when I'm working with patients, I have to be realistic on who I'm working with. If I have a patient who has a very severe traumatic brain injury, and they're going to benefit more going to the Ohio State University's Traumatic Brain Injury Network program, who will address not only the head injury but as well as the alcohol use, they're going to be better off there than for me to call a traditional treatment center. Someone who is homeless, what does that look like? in our area, there are a lot of treatment, a lot of homeless centers. They have case managers that are familiar with addiction and help people, get the help they need. But we have a special unit that's called the Engagement Center, which is the whole purpose is to engage homeless men and women who are actively using and are homeless into treatment centers. So, when I'm meeting with patients, I'm not just asking about their alcohol and drug use and the impact that it's having on their lives. I'm looking at their residents, I'm looking at their age, and what are some of the things that are coming up so I can send them to the appropriate services. Now, for some providers who are more in rural area, you're very limited and you may not have all this stuff. But if you are in an area that has all this stuff, really single out and learn what each setting does. I'm going to share this now just in case I don't have time, but with this whole incarceration, there's the whole thing of drug courts now. SAMHSA published an article. It's their award-winning newsletter back in March and April of 2006. It's volume 14, number 2. It's the SAMHSA News, March, April 2006, volume 14, number 2. And it has a nice 4 to 5 page on incarceration versus treatment. And what it does is it has some very key elements in it. It says it stops the revolving door. There's funding that's provided for drug courts. Offenders access to alcohol and substance abuse treatment instead of incarceration. It looks at adult offenders, juvenile offenders, parents who are at risk of losing their children. So what I have done when I found this is it's in a PDF format, and if I have someone who is admitted to the trauma center but is also arrested due to the nature of their crash or injury, and we have police officers at bedside, and the patient is actually handcuffed to the bed because they're actually incarcerated in the hospital, when that patient leaves the hospital, they're going to jail. And so for me, some people would say, oh, they're going to jail, never mind, and I don't believe that. No, what I want to do is I'm going in to speak with that patient. I'm asking the officers if they could stand at the door so that they don't hear the confidential information, so it's not used against the patient. But then in a envelope, I'm handing this piece of paper to them so that when they meet with their legal representation, they at least have the terminology to say, hey, I'm struggling with alcohol and drug addiction, can I get help? So that's just another way. When we start looking at treatment, we're looking at drug courts. Well, that's the key there to kind of open it up for any questions or comments.
I have one that's just partial, and so I've asked him to give me more information. So
Okay.
I'm not ready for that yet. Charles, Ben, details. Thanks.
Okay. All right. We'll keep moving until Charles provides that, and I'll answer it whenever we're available. So let's look at the treatment. And the reason I have these little arrows is because there's so many facets of treatment now. Whether it's the traditional treatment, medication-assisted treatment, drug court treatment, IDDT, which is integrated dual diagnosis, dual disorder treatment, that is out there. And I really commend the work that the professionals have done over the years to really provide treatment that is specific to each population. I believe SAMHSA just came out with a manual on addressing homelessness, individuals who are in need of treatment. So great resources. When we look at treatment, again, this is one of our studies, again, the same study that kind of looks at, what do, in the past year, where do people seek treatment? And so don't be shocked if people, say, hey, I want to go to 12-step meetings. Don't be shocked if some people say, those meetings, they, every time I go to those meetings, I feel like I want to get high or I want to get drunk. And that's a reality for some people. And so a lot of times what I explore is what meetings are you going to? Because if people, although lead meetings and sharing meetings are triggering some people because, you know, some people tell their story, and so people hear that story. Maybe that's not the best meeting. So my job is to say, hey, are you aware that there's other formats of 12-step meetings? There's discussion book groups, there's big book groups, so that they just don't have this, you know, I go, I listen to someone speak, I leave, and now I feel like I want to get drunk, you know, kind of exploring those with patients. But, you know, keeping in mind that a lot of people have obtained abstinence from substances and not gone to a formalized treatment experience. We have some of our rehab centers, our mental health centers, obviously our inpatients, our private hospitals, emergency rooms, prisons and jails. You know, there's a lot of programming that's out there. Some have been cut due to funding, but there are some that are still out there. What I find interesting that's not included in this particular study is faith-based. A lot of people prefer to go to church, speak to their pastor, you know, get baptized, you know, that's not unusual. So when we begin to talk to patients about treatment, or even when we're exploring a patient's prior treatment experience, let's not get stuck on just formalized treatment, because people have attempted to do things or to address their substance use and not necessarily go to a formalized treatment program, and we have to give them credit for that. I think that's very important. The NIDA, you know, they've said, hey, you know, treatment is very effective. The goal is to return to productive functioning. There's a reduction in drug use, crime, increase of employment prospects, and treatment is as successful as treatment for other diseases, and I think that's key. A lot of times, you know, particularly in the medical field, and you'll hear me say that quite a bit because obviously that's where I am, that, you know, we see people come in and out for diabetes or hypertension, asthma, you know, COPD, and they're not being attacked and demonized, you know, because their blood levels, their sugar level's high, or their blood pressure is high, you know, or they don't have an inhaler, they lost their inhaler. But for some reason, you know, when our patients, you know, with substance use, you know, routes in and out, you know, it's the negativity that comes with it. NIDA also had put out some, you know, this is statistic that kind of shows, you know, as it pertains to drug addiction, and is that the relapse is just as consistent with some of the other diseases. And I think until, you know, we really across board get the curriculum into the schools, whether it be the medical school, nursing schools, social work schools, that we're just not doing these 1 hour or this, you know, couple classes of alcohol and drug treatment, that people begin to understand that this is a serious illness, and that it's consistent with anything else, and that relapses do happen, lapses do happen, and that doesn't mean, you know, that you know, people should be criticized and condemned for it. This is a great booklet through SAMHSA, What is Treatment? As you could see, and kind of like faintly in the background, it says a booklet for families, but I use this for patients in general, because sometimes they said, you know, what is treatment? You know, what do you mean by all of this? And so now what I'm going to do is kind of go into kind of explaining treatment and the different levels of care and other approaches. At this time, Christine, do you have that question, or should I continue on?
He hasn't responded, but I do have somebody else.
Okay.
Okay. It says, I'm glad you mentioned drug courts. I'm currently employed as a drug and alcohol counselor with this. I do have mental health experience as well. I'm glad you have clarified the referral process and emphasized access to other services, including AOD, and take into account which type of AOD fits the client and individual patient.
Yeah,
so
it's
that's more of a comment than a question, but
okay. Well, thank you. Yeah, I appreciate the comment. I think you know, we all come from different disciplines and areas, and that's why I'm just an advocate for expert. I can't stress enough. People around here say I'm the expert lady. It's kind of a joke because I know in our area when we were beginning to address the prescription drug epidemic, and I can remember being in the room with a lot of the doctors and and nurses and the law enforcement, and we were addressing all the other aspects of how to address prescription drug, getting them off the street, doing the pharmacy monitoring and all that, but no one talked about how are we going to talk to the patient about what's been going on with them, and how are we going to access care. And so screening and brief intervention is just that ideal intervention that can be placed in multiple settings, and particularly in the court system if some courts don't have the whole drug court system set up. And you're more than willing to contact me, and like I said, there was this one newsletter that kind of goes in great detail that you can kind of explore more as it pertains to that topic. So let's kind of dive into what does treatment look like. Clearly, when we look at treatment or we're looking at interventions, we're looking at a recovery process. And as I said earlier, it's just not about drugs and alcohol. It's about how drugs and alcohol affected other areas of people's lives: marital conflict, loss of children, legal, loss of jobs. And so treatment not only addresses the substance use, because here's the thing: you take that substance use, that patient stops using. And if we don't have something in place to address all of the things that came with the using, the consequences, the guilt, shame, we're in trouble. To explore, how people even began consuming alcohol and drugs in the first place. Sure, there have been people who, for party's sake, celebratory, college, partying, and it just kind of, the tolerance kind of took a life of its own, and someone's addiction progressed in that way. But some people, drugs and alcohol use may have began as a way to feel okay due to significant abuse or neglect issues. And so, once we, deal with, the substance use, we have to address the other. Just a quick story is when my very first patient back in 1990, to be exact, June of 1990, was a young lady who came in the inpatient treatment, a history of crack cocaine. And about a week that she was there, as we began to look at the 12-step, first step work and all that, she was no longer using, but guess what? The nightmares began to happen because of the history of sexual abuse that occurred. And so for her it was very overwhelming because she didn't want to deal with that. She wanted to deal with getting off the drugs and alcohol, but she didn't, she was struggling with the sexual abuse, and so we had to address that as well. So, it's just more than getting people off the substances, and sometimes patients need to understand that as well. We have our traditional treatment, we have our medication-assisted treatment, and I'm sure I'm missing some, but these are just some I thought of: the drug courts, the dual diagnosis, primary care physicians' offices, and that's by way of medications, the medication-assisted treatment. Doctors historically have done a lot with the SOFRAM or antabuse as it pertains to alcohol. What we'll learn shortly is that there is the buprenorphine, Suboxone, Subutex, and there's also the naltrexone. Traditional support groups, that's your AA, your NA, your CA, Al-Anon. Non-traditional support groups, that's your Celebrate Recovery, and I'm sure there's a few more because now there's a lot of co-occurring disorder support groups. And then again, that website I was telling you about earlier that kind of gives you an idea of things to be mindful of when you're coming from your perspective working with other systems. What are some of the challenges or things they're looking at and working with your patient? Now, apologize if I missed any professional on here, but these are usually the people that are found in some of your providers for treatment. The physician can be either a primary care physician that's working at a treatment center. It could be a psychiatrist. It could be a psychologist. Your nurse, some treatment centers will hire LPNs versus the RNs just for funding purposes. If your treatment center is linked to your hospital system, it can look like your RNs, your counselors, and so this is kind of variety. Recovery coaches, I'm not quite sure if I said that right, but I know that up and coming there's some trainings on recovery coaches, and honestly I believe those might be the professionals that could be very helpful during the linkage process, particularly the patients who aren't able to go directly to treatment. It hasn't I've gone as far as, if a patient's interested, that if I could I've contacted Central Office of AA and NA, and they usually do a lot with institutions. So sometimes I have contacted them to say, hey, is there anyone on any of those lists who would be willing to come up and meet with this person here at the hospital and support them during the process of their discharge and all that. And there have been people who have been willing to sign that release to let that happen. And then, there are some that are just kind of shy and just kind of embarrassed and don't want it. But I believe that recovery coach, again, if I'm not saying it right, can kind of help be that linkage within the screening and brief intervention referral to treatment process. And interns, hey, a lot of times people say to me, well, Geneva, how we don't have the money to implement this system into our hospital, implement this approach in our hospitals. And I say, my first thing is I understand the financial challenges, budgeting, but be creative. I didn't think it either, but the moment I realized it, the trauma center was admitting 4,000 patients a year, emergency room and inpatient. There's no way that I was going to be able to meet that many patients. Even with we were able to hire a new counselor and I'd have internships, I still miss people that because I'm not a 24-hour, 7-day-a-week. And so there are going to be some people that we're going to miss that we have to try and follow up by way of phone, which is very challenging. So treatment levels of care, ASAM, the American Society of Addiction Medicine, to your left are the actual levels of care. And we'll talk a little bit about each of them. I'm going to use ASAM as the way to identify the care. I'm going to use SAM to give more detail about each level of care. But either way, you can go to ASAM's different website and get more information about each category. But the book I showed you earlier, What is Substance Abuse Treatment? It's terminology that patients tend to understand, so that's how I'm going to introduce you to it. To the right of the screen are the 6 dimensions, and so what happens is when a patient is referred and they go into a treatment program and they have that long assessment, which can, each setting is different, can be anywhere from 6 to 12 pages. Some people do the Addiction Severity Index. As they gather all that information, they then can go to, or their agency can create a grid, which I'll show you, and plug in the patient's status on each of those areas to justify and or support which level of care they're going to be placed in. So let me show you what that looks like. It's kind of small. It's not kind, it's real small, but it kind of gives you an idea. So if you look at the far left, you have those dimensions that I just talked about, and then it has your different levels. And we're not going to go through all this, but this is what it looks like. When I worked at the treatment center in the admissions area, we had a grid kind of like this, and we had check boxes. And after we did an assessment, we actually went, and based on where the patient fit in each category, we checked the box. And after we checked the box, it kind of spelled out which level of care that the patient would go into. Now, why is this important? It's important that when you're sitting at bedside or whenever you start talking to a patient about treatment, again, remember, their assumption is always residential treatment. But what I always say is I'm not quite sure what level of care you're going to be admitted into because you have to sit down with someone and have, a longer assessment, and between you and that individual, you guys will decide which level of care you fit in. What I like about the levels of care is what happens is when a patient is placed, say like in level 1, which is outpatient, and we'll talk a little bit more about what that looks like. But if they are unable to abstain from drugs and alcohol at that level of care, they then can be upgraded to an intensive outpatient and or residential treatment. Now, the ideal is that there is a agency that has all of that, and based on where I worked in the past, it did. It had everything from your detox, your early intervention level 0.5 all the way up to your level 3, and even your long-term treatment. That if a patient was not able to stay clean, we were able to, within the same system, upgrade them, kind of like a hospital, ER, OBS, inpatient. Now, one of the challenges of this whole thing is based on when you stop and look in your community where your patients are, and you say, oh my goodness, we have outpatient over here, But if they're unable to stay clean over here, then they have to go to residential over here, and that's just the reality of the treatment system. I mean, not every agency has the funding, or every county or state has the funding to create one comprehensive system. So just kind of keep that in mind in some cases. But within the treatment system, they know that whole thing and can access people to the appropriate levels of care. And what happens is, let's just say a patient's admitted to the residential treatment. A lot of times, once a patient completes a 7-day, 10-day, 14, 21-day, 2 months, 6 months, however long program, it's natural that they will then get stepped down into your intensive outpatient or outpatient for that ongoing aftercare. Now, when we look at outpatient treatment, it varies from agency to agency. All of these vary from agency to agency, but I'm just kind of giving you a general idea. It can be, the programming can occur anywhere from morning, afternoon, to evening. A lot of times it's based on people's schedule, work schedule, school schedule. At a specific location, usually 1 to 2 times per week. It lasts anywhere from 8 to 12 months or longer, depending on how the patient does. Normally there's random urine screens per week, or call in, and if if a patient is called and there's a certain number, they have to come in and drop a urine. That's another way. It's usually individual. Sometimes it's only individual, but a lot of times it's individual and group. And usually there's a family education system, usually for the whole agency, not specific programs such as outpatient services. I always encourage, if the agency has a family educational support, that group, that family members are asked to come to that. Because it's very, very important. Now, family members, they kind of have a different point of view. It's nothing for a family member to drag their loved one into treatment, kind of like say you have them and fix them and bring them home, and so it's always good that families are involved to understand what's going on as far as the disease of addiction, the impact on the family, and aftercare. Then we have what's called intensive outpatient and partial hospitalization. You're going to hear a lot of partial hospitalizations and inpatient and intensive outpatient when you're dealing with insurance companies. Sometimes it can get confusing, but I try to break it down. Again, it can be morning or evening program. Particularly for your IOP, specific location, patients usually residing at home. Your IOP is usually weekly attendance, anywhere from 9 to 20 hours a week. So sometimes what that looks like is 3 hours in the morning or afternoon or evening, 9 to 12 or 2 to 5 or 6 to 9, and they may come 3 times a week plus do individual. Where your partial a lot of times is daily attendance, kind of like the patient goes to school or goes to work every day. They'll come to treatment every day, and then they go home. And a lot of times the treatment programs ask folks to go to 12-step recovery meetings. Still, you have your urine screen, individual group counseling, and then family. When you look at inpatient, now we're looking at someone actually residing at that location. It can be linked to a hospital or a freestanding facility or clinic. A lot of times it's 7 to 28 days. Historically, in the early 90s and prior, it was pretty much blanket 28 days. The insurance companies, began to look at outcomes and really didn't see where that was beneficial, or the outcomes were not all that great, and that's when the insurance companies kind of came in and said, okay, we're going to be the one managing it. So a lot of times patients will have an assessment, and then you call the insurance company. The insurance company has their grids, and then they determine where the patient falls, tells you as an agency how long that patient has inpatient, and then you got to call them back on that 3rd, 4th, 5th day, sometimes the next day, give them all the information, and they will then determine if the person stays inpatient or gets stepped down. A lot of daily programming, morning to evening. Sometimes on the weekends there's transitional weekend passes to try and transition people back into their families or communities. Definitely substance use monitoring upon returning home. Sometimes it's a phase system. We have our individual group counseling. A lot of the 12-step meetings are in-house, usually in the evenings. A lot of times they'll have a lot of speakers that will come in and kind of share their experience. Also, art therapy, physical therapy, that's real huge. A lot of times, some patients who are challenged by ability to read and write, and those who don't have challenges, sometimes doing art therapy, drawing a picture, cutting out pictures of a magazine, and and putting them on a piece of paper, trying to help patients get a better feel on how they're feeling, and a lot that's going on in their lives. They use a lot of art therapy. Physical therapy obviously is to get people, you know, moving again and walking, and a lot of exercise. You have some facilities, whether it's private or public, that have very nice, you know, settings. You know, some are very limited. And then of course field trips. When I worked at a treatment center, you know, it wasn't unusual for us every month to do a field trip. A lot of times it was in the go to a park or something. It was amazing to see patients begin to just have fun again and laugh. And it's usually kind of like this picture. The reason I picked it, it's usually at the end of the day where we would sit around, and it would really bring people to tears to begin to talk about, you know, what it was like to have fun again. Now we have our residential treatment, and you're like, okay, well, what's the difference between inpatient? A lot of times your residential services is still inpatient, but sometimes it can be a lot longer. This is where you may have a women's long-term program, a men's long-term program. I know we have one in our area that has multiple phases, and it's phenomenal because women can actually stay at this facility for 5 years, and the ones that stay there 5 years a lot of times have children. But some people can actually complete the program in 1 year, 2 years, or 3 years. But I mean, they're not only dealing with substance use. I mean, they're dealing with so many facets of life. You can kind of see it. Phases of treatment is real huge, and it's really rewarding for some of the women to do some of the work that they do, and then go to the next phase. In this area, it's Amethyst Incorporated is one of our agencies here. We have a great women's program in these areas, and what was amazing is that they created kind of like a college setting, and that the women live in these apartment complexes, and they actually have to take the bus down the street to the actual location, and they set up their programming as if they were going to college. And so if someone had self-esteem challenges or anger, or sexual abuse, they would be assigned to this 9-week, 10-week course. They would do a pre-test. They do, you know, homework, group, all this, you know, all these activities, and at the end they would do a post-test. And based on the pre-post test, based on how they did, and the treatment team, the patient then could move to another course. So it was pretty fascinating how they created that. But these are great opportunities for men and women to kind of really get on their feet. It's tough because it is so long that some people are just like, absolutely not. I'm not, you know, going to treatment that long. And so a lot of times, you know, I don't even mention long-term treatment to most patients, obviously, just because it can overwhelm them. But for those who've had prior treatment experience, I kind of can get a gauge just based on my experience on if this would be an okay topic to bring up. And then we have our medically managed intensive inpatient. This is usually called detox. This is where medication is required to help the patient withdraw off the medications. Some are freestanding meaning that they kind of set alone. They're not attached to a hospital setting. Obviously, the hospital settings, a lot of times, sometimes detox can get so severe that patients really, a detox just really can't. Some detox centers just can't manage the health of some patients, and so they actually have to go into a hospital setting and experience our detox that way. There is a utilization of medications based on what the patient was using, and so there's protocols for patients with alcohol, benzodiazepines, opiates. Patients stay at the facility until medically cleared for discharge. The best way to describe it is more like a hospital setting. Medically supervised, usually it's your nurses and your physicians that manage this. You usually will have your counselors and techs that kind of manage the groups and all that. This isn't where you're going to do any real deep group therapy, obviously, because people are on medications, not feeling all that great, but there are individual counseling sessions, educational groups, videos, speakers, and an introduction to some of the 12-step programming. Now, so those are some of your formalized treatment levels of care. So I'm going to open it up before we dive into medication-assisted treatment to see if there's any questions.
I just had somebody ask you to go over what happens when law enforcement gets involved.
Well, law enforcement can be very tricky because law enforcement, when there's a warrant or something like that, they can trump um, treatment centers, meaning that someone can be inpatient and they can come to the treatment facility and obtain patients. Now, if this happened, a lot of times, you know, again, it's good that law enforcement kind of knows the treatment center and staff work together. I never, ever think it's a good idea that police just come in saying they're going to get somebody and they go to that unit. I believe there's discretion. I believe, you know, people need to be respected and handled with dignity. So a lot of time we would get our CEO involved, the manager of the unit. We would then find out what the charge was. And a lot of times the officers were willing for all this to happen. We would pull the patient out of the setting and to a private room to kind of let them know what's happening, and that, you know, right now law enforcement, you know, pretty much has to come to arrest them. And then we usually would put them in a particular room that was secluded to kind of avoid any, you know, public humiliation. I can't say every facility does that. I know some of the challenges is particularly people who were in detox and on medication, so we usually would have to get the nursing staff and medical team involved. If this person was going to a jail, could they continue to manage that person medically? So there are some things that took place, but yeah, that happened on numerous occasions, unfortunately, but it happens. Any other questions or comments?
So far, no.
Okay, we've got about 10 minutes. Medication-assisted treatment, it's been around for a very long time. People have not been all that receptive of it. Some people have not been all that receptive to it, particularly your abstinent-based programs. Your traditional programs that I just explained to you primarily are abstinent-based, meaning that they're not wanting people on any kind of substance. So that's where you have your methadone clinics that will administer methadone at those clinics, which also will have programming set up kind of like what I just described to you, the difference being patients have to show up every day in the morning to get their methadone and then participate in some kind of programming throughout the week. Methadone, what I find, particularly in a hospital setting, is whenever I see a patient come up positive for methadone or a report of methadone, I want to meet with that person immediately, because it is a long-acting opiate, but when that person starts going without that methadone, they're going to go into some severe withdrawal. So what I will do is I will go in to see where this patient's getting their methadone. Are they part of an addiction clinic? If so, our pharmacy needs to get involved in order to contact the methadone clinic to get the right dosing, and then I work with the counselor to make sure there's a smooth transition and they know what medications the patient was on, so that's not held against them. But you have cases where patients are on methadone for pain management purposes, same thing. Pharmacy needs to get involved, the nurse practitioners have to get involved in order to contact the doctor so that they can, you know, prescribe the patient the right medication. But then there's those patients who are getting it off the street. A lot of people, I mean, you have to really look up the methadone. There's a lot of proven evidence and effectiveness of methadone, particularly when it comes to reducing of crime, reducing of some of the different infectious diseases and all that. So the evidence is there. Some people struggle with it because some say, well, it's trading one addiction for the other. You know, I don't believe in that. I think if we're looking at addiction being a disease, we're prescribing medication to people with high blood pressure, asthma, diabetes. Why not prescribe this? Why not prescribe medication to people who are addicted to substances? Whether however long they're on it is between them and their doctor, but it is beneficial. You have the Suboxone. You might also hear Severity. Another name might be buprenorphine. It's one of the newer medications that's been approved. There's a lot of information on it. There's a form of an agonist and an antagonist component where it kind of blocks and wipe off the opiates, you know, on the receptors, but also will address any of the withdrawal and negative results of coming off of opioids. A lot of this is being implemented in treatment centers, but A lot of it also was with private physicians. It can be very expensive. Some doctors are prescribing this medication and charging astronomical fees. Therefore, some people cannot get it. But there are some treatment centers who serve the indigent community who are starting to prescribe this medication. And then there's another medication that's particularly for opioids is your naltrexone. And naltrexone also blocks opiates from acting on the brain, and it takes away the reward of getting high on as it pertains to the particular drug. So these three, a lot of methadone's been there for a very long time. Naltrexone, there's a lot of research that's being done on that. A lot of people are using it. There's a lot of information on Suboxone. For Suboxone, you can go to, and I believe it's on the end of this slides when you get it, naabt.org. That's N as in Nancy, AA, Apple, BT.org, where you can get phenomenal information on buprenorphine and Suboxone. The antabuse is one of the older medications, also known as disulfiram, that doctors were prescribing for patients who had a history of alcohol use. These are just a few of them, but the main thing I want to get out there is that it's just not about traditional treatment. It's about medication-assisted treatment. What a lot of people don't realize is when you look at medication-assisted treatment, they are recommending that people are receiving counseling and 12-step or support meetings in conjunction with this. There are some doctors that's just prescribing the Suboxone and not asking their patients to do anything. I'm not a believer in that. I believe people still need counseling to begin to address some of the other things, because the medication is only treating the symptom, the withdrawal symptoms. It's not addressing, that medication is not addressing the psychosocial issues, and it's not addressing some of the medical problems that are contributed due to the drug use, alcohol and drug use. Here is kind of where some of these settings are located in our area. It's been at treatment centers and clinics, like I said, physicians' offices who have been certified in prescribing the buprenorphine. The methadone, you can't. Methadone addiction, methadone has to be done through a clinic. Methadone by a physician's office is primarily pain management. There are some urgent cares that have kind of come up prescribing the buprenorphine, primary care doctors, addictionologists, and then of course here are some of the on the services. Those mimic kind of what we've already talked about with some of the traditional treatment, kind of supporting more than just medication. This is just an example of IDDT is what you've probably heard. You can get an actual kit on SAMHSA's website that really goes into detail how you can implement this into your system. Just out of for time purposes, I really can't get into all this, but I wanted to give you an idea of what else is out there for dually diagnosed patients with co-occurring disorders. That's been very helpful. What has happened is a lot of treatment centers are starting to use, traditional treatment centers are starting to look at doing IDDT or training their chemical dependency counselors in mental health so that they can address both. And a lot of your mental health centers are starting to train their mental health professionals in substance use. Historically, it used to be two systems, and patients were being bounced back and forth between both systems, rejected from one, rejected from another, and now it's starting to become very integrated. Great resource. What I'm going to do is, just due to time, I put this little manual up here just because you can get this from NIDA. What are the principles of addiction treatment? We've talked about some of them, but I think it's just really true of what we all need to understand is that it is a very complex disease that affects the body. There's been a lot of research on the effects on the brain. Hazelden has a great DVD on neurobiology, I believe it is. I can get with Christine and kind of give her an idea of because I don't know if I'm getting the name right, but it's a great DVD, an hour long, that I show all my students when I teach at the universities, as well as new nurses that are coming in. One single treatment episode may not be appropriate for everybody. We talked about the relapses. Relapses are real. No, we don't want relapses, but the truth of the matter is it does happen, and we need to embrace patients. Treatment needs to be readily available. We've talked about that. That is a huge problem right now. And always remember, of that 20.6 million people that the NSDUH identified in 2011, if that 20.6 million, that 95% sought treatment today, they would not get the help they needed because there's not enough treatment centers. That's why screening and brief intervention also has to be implemented in a lot of these settings so that we can begin, so patients can at least begin to have the conversation. Effective treatment attends to multiple needs of the patient. Remaining in treatment for an adequate period of time is critical. A lot of that depends on the patient's assessment and where they are in their treatment levels of care, the different therapies that are used in the treatment center. We talked about medications. An individual's treatment and service plan must be necessarily assessed continually. So, just because a person goes in and they're assessed on, day one, assessment has to continue to kind of see where a patient is growing and where there's some challenges. Some patients have mental health disorders. We talked about medication-assisted treatment. Treatment does not need to be voluntary to be effective. One of the things people always talk about, whenever I hear one of the nurses say they haven't hit their bottom, I don't believe in that. Everybody's bottom is different. Someone's bottom might be the loss of a wife. Someone's might be the loss of the children. Somebody it might be the judge. For somebody it might be their job. So when people say they haven't hit their bottom, I'm always shocked because we don't know people's lives and we don't know what one's bottom is. So I'm always ask the nurse, and they always kind of look at me. I'm like, well, what does that bottom look like? Well, he or she usually doesn't have an answer because they don't know the person well enough to determine what that person's bottom is. So that's just a pet peeve of mine. Thought I'd share it. Drug use during treatment must be monitored. Obviously, in treatment should test patients for presence of other illnesses and link them to services. Now, when we look at treatment, and we're just towards the end here, the middle part, usually all in the white black boxes, is what we've talked about already. The intake, the therapy, the counseling, the case management, the medication, the support groups, continuing care. This is what the treatment center does. The blue lines may or may not apply to each patient. It's very overwhelming when you have a patient that needs all of those blue needs met. Very overwhelming. And it has happened. I've worked with some patients. It's a lot. But what it means is treatment centers usually have to have agencies outside of their agency, in order to help with some of those. So that kind of gives you everything that happens in a treatment system. And then in closing, taking it to the wire here, these are some of the references that I referred to earlier where you can get a lot of information as it pertains to a referral and treatment. And like I said, SAMHSA just came out with the expert implementation that could be very helpful. So with that, I'm going to close with that, and if anybody has any questions, I'm more than willing to answer, and I will make sure I get this PowerPoint to Christine so she can get it out to you.
Wow, a lot of material. Thank you so much. I don't have any other questions. I know people want to review part 1 again, and I'm sure they'll be reviewing this because you have it so jam-packed with information, and we really appreciate your time doing this.
Absolutely.
Thank you.
Thank you.
I think we're done now. I will be turning this off, and remember, look for an email from me